Bioteque Corporation is a leading medical device manufacturer in Taiwan. We are proud to introduce Bioteque over-the-wire dual-lumen balloon dilatation catheter, sheath introducer set, and hydrophilic guide wire in percutaneous angioplasty for salvage of the non-functioning arteriovenous fistula. This new over-the-wire dual-lumen balloon dilatation catheter features a low-compliant balloon with material reinforced nylon, which provides powerful penetration to obstructive lesions. The inflated balloon provides excellent abrasion resistance when compressing the venous stenosis. A high-pressure balloon, 6x40, provides up to 21 atm of dilating force, producing effective dilatation. Each balloon has platinum-chromium alloy radiopaque bands with excellent radio opacity. A taper balloon tip design ensures smooth transition between the guide wire and balloon tip, enabling to pass through acute curves, while the premium balloon pentafolding process helps lower profiles and improves refold. A balloon refolder is offered for free in each pack for balloon refold. This design offers high-performance treatment of obstructive lesions on native or synthetic arteriovenous dialysis fistula. Bioteque has engineered with input from clinicians working on the front line on fistula salvage. Now you can see our demonstration of the Bioteque sheath introducer set. First, the smooth taper from the dilator to sheath facilitates uncomplicated sheath introduction. The easy entry and low insertion force. Non-kinking design keeps lumen open throughout the procedure. Our redesigned and improved hemostasis crosscut valve accepts a broadened range of catheters and guide wire sizes, while preventing blood reflux and air aspiration. Biocompatible copolymer with barium sulfate blend, barium sulfate 4, ensure correct placement under fluoroscopy. Rotating suture wing allows for quick sheath repositioning. The sidearm tubing, equipped with a three-way stopcock, allows flushing around the catheter while it is positioned inside the sheath. Luer locking dilator and color-coded introducer cap for easy identification of introducer size. Available in a wide variety of sizes and accessories for your procedure needs. The Bioteque hydrophilic guide wire is composed of a nickel titanium, also known as nitai or nitinol, core wire, jacketed with a durable polymer that is receptive to a coating. The polymer resin is blended with tungsten, a radiopaque metal, and affixed to the core wire via adhesive. The jacketed core wire is then coated with a hydrophilic coating. Hydrophilic guide wire is extremely slippery and used in a variety of cases to navigate tortuous vessels and cross lesions. First, inject saline solution into the Luer lock hub of the guide wire dispenser using a syringe. Then, to activate the hydrophilic surface, Bioteque hydrophilic guide wire has to be reflushed in order to remove the guide wire from the dispenser. Its nitinol core and hydrophilic coating ensures smooth guide wire trackability, improved introduction into target lesions, as well as reduced device friction. For safety, versatility, and ease of use, let the Bioteque hydrophilic guide wire design help you manage the placement of devices during diagnostic and interventional procedures. AV shunt. Two factors are necessary for an arteriovenous fistula, AVF, to be usable as dialysis access. It must have adequate blood flow, and it must have a size that will allow for cannulation. For effective dialysis, the AVF only has to deliver a blood flow that is marginally greater than the pump rate. Unfortunately, dialysis may not be technically possible in these cases with lower flow because the AVF does not mature sufficiently to a size adequate for cannulation. The presence of venous stenosis could be diagnosed by physical examination. After documentation by angiography, the patients were treated with angioplasty. We now introduce two cases using Bioteque angioplasty balloon, sheath introducer, and hydrophilic guide wire. The first case, patient with total occlusion of the synthetic bridge graft. As we can see from the fistulogram, this case shows a patient with total occluded synthetic bridge grafts that bridges the cephalic vein and brachial artery in the dominant right arm, and we also found a central thrombosis, central venous occlusion, in the downstream portion, V venous, and we are now using Bioteque over-the-wire dual-lumen balloon dilatation catheter 7mm by 40mm hydrophilic GW to proceed with PTA, percutaneous transluminal angioplasty. Now, the AVF needle was inserted into the cephalic vein adjacent to the loop forearm graft. Pull back the syringe attaching to the AVF needle hub to apply negative pressure. No blood flow returns, only black blood clots. Stabilize the needle with a piece of tape. Place the AVF needle in the brachial artery adjacent to the loop forearm graft. Pull back the syringe attaching to the AVF needle hub to apply negative pressure. No blood flow returns. We now ascertain the graft is totally occluded. Stabilize the needle with a piece of tape. Wipe the pre-flush guide wire. Advance the guide wire into the dilator down to the AVF needle via the cephalic vein, first to the upstream portion brachial artery. Wipe the pre-flush guide wire again. Then advance the guide wire into the dilator down to the AVF needle via the brachial artery to the downstream portion, auxiliary vein or subclavian venous, under fluoroscopy. Prepare for balloon catheter insertion. Insert the dilator through the guide wire to dilate the tissue, so we remove the AVF needle from the brachial artery in the right arm. Start balloon introduction through the brachial artery. Then remove the AVF needle from the brachial artery in the right arm. Insert the dilator through the guide wire to dilate the tissue. Insert the balloon. Carefully advance the balloon counterclockwise over the pre-positioned guide wire through the cephalic vein. Prepare for drug injections. Advance the balloon introduced through the cephalic vein counterclockwise over the pre-positioned guide wire, extending from the cephalic vein first to the upstream portion brachial artery. Remove the guide wire. Then inject contrast, first to ascertain if the graft is totally occluded. Then the patient was sedated by injecting Dormicum and Rapamycin 3 cc to alleviate anxiety and control pain. Inject saline. Then pull back the balloon approximately 5 to 10 centimeters, close to the loop forearm graft on the arterial side. Inject heparin 3000 mu. Inject urokinase 50 kmu and saline. Throughout the surgical procedure, all of the vital signs, including blood pressure, breathing, heart rate, and oxygen saturation, were being maintained at very close to their ideal levels. A PTA was performed as follows. Remove the pre-positioned guide wire extending from via the brachial artery to the downstream portion, auxiliary vein or subclavian venous. Blood flow returns. And then inject contrast to check venous stenosis condition on the side of the proximal part. We found a central venous thrombus here. Connect the male rotating adapter of the inflator to the inflation port of the balloon, introduced through the brachial artery. Tightly secure the hubs to one another. Proceed with angioplasty and pull back the balloon in the upstream portion, A. arterial, all the way to graft venous junction, graft. Secondly, detach the male rotating adapter from the inflation port of the balloon introduced through the brachial artery. Then connect the male rotating adapter to the inflation port of the balloon introduced through the cephalic vein. Proceed with angioplasty and pull back the balloon in the upstream portion, A arterial, in the first place to graft arterial junction. Then pull the downstream portion, V venous, all the way to the arterial graft junction, graft. Insert the guide wire and angioplasty is repeated for residual stenosis. Remove the guide wire and inject contrast, and an angiogram was made on the remaining thrombus and stenosis condition. Detach the male rotating adapter from the inflation port of the balloon introduced through the cephalic vein. Then connect the male rotating adapter to the inflation port of the balloon introduced through the brachial artery. Pull back the balloon to the downstream portion, V venous, and then proceed with angioplasty all the way to graft venous junction. Inject contrast, and we found only one remaining thrombus on the arterial side, which will be fixed later. Later, follow the angle to the tube of image intensifier to go all the way back to the subclavian venous. A big thrombus in the central venous was found. Insert the guide wire and torque into the hub of the balloon introduced through the brachial artery. Inject contrast into the port of the balloon introduced through the cephalic vein. Proceed with angioplasty and pull back the balloon in the downstream portion V venous all the way from venous graft junction to cephalic venous. Keep advanced guide wire with torque in the brachial artery balloon hub, using a counterclockwise twisting motion, until the central venous thrombus is penetrated. The balloon is placed over the pre-positioned guide wire through the lesion. A further and repeat angioplasty and thrombus fragmentation are done until full patency is achieved. Detach the male rotating adapter from the inflation port of the balloon introduced through the brachial artery. Then connect the male rotating adapter to the inflation port of the balloon introduced through the cephalic vein. Remove contrast syringe. Insert guide wire and torque into the hub of the balloon introduced through the brachial artery. Proceed with angioplasty on graft arterial junction. Inject contrast into the port of the balloon introduced through the cephalic vein, and make the final go-through using image intensifier on the right arm, and the angiogram showed a nearly significant effect on graft patency. Even though there is remaining thrombus, there is no need to have an additional procedure to clean up any remaining thrombus. A repeat angiogram was performed to verify the result of the PTA. When the last thrombus fragmentation are done and satisfactory angiogram is obtained, the entire procedure is completed. The second case. Patient with radiocephalic fistula with stenosis adjacent to the anastomosis. Now, let's see what we have in the second case. This lady has a radiocephalic fistula with stenosis adjacent to the anastomosis. We now need to correct the stenosis. We can see the side-to-side anastomosis at the end of the cephalic vein to the side of the radial artery in the forearm of the dominant arm. A fistulogram was performed as follows. The fistula was entered just above the arterial anastomosis using an IC needle. The guide wire was inserted into the vein. And was used to introduce a 5-fringe sheath introducer. A Bioteque 6mm by 40mm angioplasty balloon was used to treat the stenotic lesions. Contrast was injected through this dilator to visualize the fistula and draining veins up to the level of the subclavian. Dilatations of 10 to 12 atmospheres were used. As we can see from the animation and video, radiocephalic fistula stenosis has been corrected using angioplasty. The information and particulars provided by Bioteque Corporation are accurate, true, and complete, and are given to the best of our knowledge and belief. Accurate diagnosis and localization of problems that have contributed to the failure of a newly created AVF to mature is primarily dependent on angiography. Fortunately, venous stenosis does not occur in AVFs with the same degree of frequency as is seen with synthetic grafts. Please consult with your physician to discuss any questions you have concerning your medical conditions and find the most appropriate treatment option for you.